we're talking about advanced techniques in vertebral augmentation and kyphoplasty procedures. Here with me is Dr. Dion Raza, neurology trained fellow, now doing interventional spine fellowship. So welcome, Dr. Raza. We will be going over different techniques for vertebral augmentation, more advanced techniques. And, I have to make sure we are acknowledging and paying tribute to pioneers like yourself, Doug, in pushing the frontiers of vertebral augmentation. And, I know Ben is going to bring up a slide. I think we want to show that now. A lot of these techniques were developed by Doug. We're going to go over these techniques, and on the left there, Doug, I know you're too humble to advertise your book, but for everyone who's looking to look at more advanced techniques and a comprehensive guide to vertebroplasty, kyphoplasty, implant augmentation, that's the book to get. So thank you very much for all your work in pushing the elements in not only vertebral augmentation, but in interventional spine and interventional pain management. And also to you and Neil in pushing the registry for techniques like kyphoplasty, so that insurances like Noridian can and look at it from a evidence-based point of view and show that it really makes a difference in helping our patients. So thank you very much to you guys. So we'll be going over a few things here, but first of all, let's kind of go over some of the technologies. Today we have Catherine and Erica has out here in comparison to the 1.0, or the first version of the, first of all, is an ablation device to help with osteolytic lesions, metastatic lesions to the vertebral body and spine. So the benefits of that and how that probe works is that they're feeding fluid through the active tip, and that's cooling the active tip, and that's actually allowing a larger lesion, but also preventing charring from occurring compared to other ablative devices. Some of the benefits of the newer version of the is that now they're able to do 2 levels at a time. So instead of these, you can see these 2 probes in the transpedicular approach. We're getting into the vertebral body, and you see each of the probes is providing a nice elliptical type of lesion, and together provides a larger elliptoid type of lesion that helps encompass the majority of the body. But with the 2.0, we're able to now use 4 probes, and if you're doing a lesion for majority of the body, you're doing 4 probes at a time. They will act independently, so they're powered independently, those 4 probes and 4 channels. So that's a nice benefit to be able to get in half the time if you're doing more than 1 level at a time. Okay? So to go over some of the techniques that we're going to look at from more of a unipedicular approach. So as many of you learned, that the transpedicular approach is something that's done in a bipedicular manner. It's taught quite readily, but today we're going to go over more of the unipedicular approaches that one can use, and was developed by none other than Dr. Douglas Beal. So thank you, Doug. So in terms of the actual extrapedicular approach, so how does one approach that? So, and when does one use that? So in patients with a lot of hardware, it's hard to get that pedicle, the needle through the pedicles because there's a pedicle screw there. So you have to get underneath it. Or in patients where there's severe collapse of the vertebral body. Another instance where we have to get into the body without a difficulty in getting to the area. So this is a way we can get through the lateral portion of the body safely and into the area to provide cement into the central portion, okay? So we're gonna go 45 degrees contralateral to me. Oh, first of all, take a picture there, first of all. Let's have a look. Of course, we're gonna want to make sure, we're gonna do the level at the L2 level there, the level just above the one with the spacer there. Looking at L2, so you want, first of all, sharpen the end plates. You want equidistance of the spinous process to the pedicles there, and nice and lined up. So it's decently lined up. Maybe the superior end plates maybe a little bit off, but go cuddle tilt live for me, please. Yeah. Good there, excellent. And we'll go to a 45-degree angle towards you. Excellent, thank you. And you do a picture there for me, please. I can show the X-ray, thank you. Picture here. So in terms of the anatomy, we're trying to make sure we're staying away from the mid portion of the vertebral body. So picture there. Picture there. Picture there. Picture there. Picture there. So what runs through there is a radicular artery. We're trying to stay below that line, and we're also, we're trying to stay away from the posterior area of from the pedicle. Picture there. Picture here. Here. Picture here. And here. So we're trying, picture. Here. So trying to stay away from this picture there. Picture. Trying to stay from this area here, and we're trying to be more anterior to that area. Okay? Back to the X-ray, please. Picture. Picture. So it's saying anterior to the pedicle and staying inferior to the midline of the vertebral body. Picture there. Picture there. And there. Give a scalpel there or something. So kind of a safe zone in this extrapedicular approach. So imagine if there's hardware there going through the pedicle. This is a way to bypass that area and get into the vertebral body safely. Picture there. Picture. 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 And Doug, do you want to describe how you went about discovering this type of approach? I thought it was quite an interesting story. Picture there?
Yeah. So
picture.
We know that we need more than just a transpedicular approach. The extrapedicular and the parapedicular approach were conceived as a way to get around hardware. So the parapedicular approach and the extrapedicular approach, we took 11 cadavers and we dissected down to the spine, leaving all the neurovascular bundles intact. And we found the areas that were relatively hypovascular and aneural, and we painted the neurovascular bundle, the nerves yellow, and we color-coded the arteries and veins, and we looked for the areas that were that had the least amount of vasculature and nerves. And so this is done. I don't really like measurements. So if you do a transpedicular approach, you kind of go centimeter up, 2 centimeters out, and you come in at 10 o'clock or 2 o'clock. Parapedicular approach is one vertebral body width on a line that goes from superior ipsilateral to the contralateral inferior corner, a line that goes up there, a vertebral body width out. That turns out it's just a wider approach. It's along the exact same trajectory as a transpedicular approach. And then the modified inferior end plate extrapedicular approach is the full name of this, is the area that's behind big red and big blue, below the radicular artery, and in front of the descending nerves. So in that area, that hole, you can put your thumb in the vertebral body through that area. There's hardly anything there. So if you want to get big appliances in the vertebral body, or if you want to get around hardware or a very compressed vertebral plana, for example, you can't make the angle coming in from the top. This is a very good approach to do that.
Excellent. Thank you, Doug. So now, as we enter the vertebral body, this portion of the body can be very, very fragile and get through the body quite quickly. So in osteoporotic bones, you got to be very, very careful. So hopefully this is not as soft, but let's go back, let's check with let's check an AP view, and then we'll also, of course, go to the lateral view, but we won't advance any further at this point. Picture there. The camera's down there. Yeah. Let's go oblique towards me a little bit. Picture there. Excellent. So we go towards the center of the vertebral body. Picture there. Get a lateral, please. So in a lot of these uniparticular approaches, and this, of course, gets you quite close to the central portion of the vertebral body. So pretty anterior there. Back it up a little bit. Picture there. Now, at this point, kind of go back a little bit more. We use some of the devices that the companies have. If I the curette. We could use some of the devices that they have. For example, the curette here. Can we show that here at all? It's kind of helps to bore out the bone in that region. It helps if you want to get more medialized or more lateralized before using the balloon and put it at different angles. Or a 45-degree angle, or more to a 90-degree angle. And then kind of windshield wipering, if possible, to get more of a directional core out of the bone. And then other ways we can get in, if we are very lateral in the vertebral body, are curved needles such as this to get in the region. But in this case, we're entering very centralized in this type of approach, especially. Here we'd now get a balloon inserted, but first of all, I'd core it out, and then insert, deliver the cement overall. But questions regarding this approach and why we do it, and what are the things to look out for?
Hey, this is Gavin. You may have mentioned at the beginning, is there a specific angle you oblique to for the inferior end plate approach?
Yeah, oh, sorry. Yeah, I went to approximately 45 degrees. Doug, is it something you're looking for, Doug?
No, that's it. It's a 45 degrees, and that number came from looking at 1,000 consecutive CTs and measuring that angle on those CTs. And that's the angle that's safe, even though this looks like an approach that's far out, and even though it looks strange, and even though, I've had people walk by my room, look in, and like, what are you doing? Okay. Seriously? Yeah, it looks odd, but it's a safe approach.
But it's a nice approach to get into the vertebral body. Again, we see a lot of patients where they unfortunately have a collapse within the constructs of our surgical partners. And it's a good way to get in safely. As Doug was saying, how to get in safely is, stay inferior to that radicular artery or the central portion of the vertebral body and staying anterior to the pedicle there, and it keeps you in a nice safe zone and to get in quite nicely. A very useful technique in the unipedicular manner.
Yes, indeed. Questions, comments? Thank you very much, Dr. David. Well done.
Well, we're going to now do the parapedicular approach.
Yes.
Of course, not as you kind of described earlier, and let's go to AP. Yeah. Of course, it's using the same line that we're using for the actual transpedicular approach. Where's that little pointer? The pointer. Let's use this one's fine. And picture there. Oh, here it is. Sorry. That's a little picture there. Picture here. Picture here. Picture here. Picture here. Here. So as Doug was saying, we're using the same trajectory line as the transpedicular approach, but now with the actual parapedicular approach, we are measuring approximately one vertebral body laterally. Picture there. Picture. 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 So approximately there is our crosshairs is where we'll enter to get at the approximately 10 o'clock position on that area, but we're going to be going just anterior to the entrance of the pedicle there. Let's get the Jamshidi. Picture there. Picture there. Picture there. And there. There. I'm trying to feel a bone there. Picture there. Picture there. Picture there. So just a little more anterior to that picture. So picture there. There. And there. Picture. 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 Slipping out. Picture. Picture. So to check where we're at, we can go to about a 20-degree ipsilateral oblique towards me. More of an en-face type of view. Let's have a look right there. Oh, 20 degrees there. Thank you. 20 to 30 degrees. See, we're just anterior of the area. Picture there. Oh, sliding off a little bit, sorry. Picture. And picture there. Okay. And we go to now a AP view. Picture there. Picture. Picture. That's pretty hard. Picture. 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 Of course, we're making sure we're staying away from the medial line of the pedicle there. Keep yourself safe. As we get closer to that medial line, we will be switching over to a lateral view. Picture. And closer there. Let's get to the lateral now. Let's have a look when you're ready. And as you can see, We've entered, we're entering the past the posterior border of the vertebral body, which means we're safe. If we had not yet entered that area, to note, you want to make sure you go and back it up, and maybe at that point use a beveled tip to change over to a beveled tip. I'm not sure the beveled tip.
You have a bevel?
Close up on that. Go to a beveled tip, and that way we can go geared more towards the lateral side of that pedicle, so that we are not transgressing into the canal, basically. So good ways to keep yourself safe, but of course we don't want to transgress that medial border of the pedicle too early. Okay, so at this point we advance. Well, that's good. Alan, thank you so much. Looking at the mid to anterior portion of the vertebral body. Let's bring it there. Let's check a AP, please. Oblique towards me. It's got a little bit more tree AP. Excellent. So we're going to right mid portion of the body there. Look, and both these approaches enable us to get to that central portion of the vertebral body. So that's the power of these approaches that's Doug has developed. So I want to make sure that you're not always able to get there. Let's say you did a more trans-pedicular approach, and you weren't able to get to the central portion of the vertebral body. But here, if we did this approach, we would be able to now maybe core it out a little bit with some of the tools that we talked about earlier. They also have a curved needle. They also have a blazer, and I'll kind of display what we would do with the blazer in a second here. Okay. So this is access for what? Okay, we can just do that now. Yeah. And meanwhile, you want to go ahead and mix? Yeah, why don't you go ahead and mix the cement? But we'll now show the cement. But meanwhile, go ahead and mix, and I'll show the blazer device that. So yeah, let's say we did a trans-pedicular approach. At this point, we'd use the blazer device. We'd come through and see this nitinol curved needle comes out. As you see, it protrudes out about 2 centimeters out, okay? And it is channeled so that you can deliver cement through it. Okay? But it's a good way to get across the vertebral body in a uniperpendicular manner. And getting across, creating channels, backing it up, creating more channels, inferior, superior, windshield wiping if the vertebral body is quite soft. It's a good way to get access uniperpendicularly if you did a trans-pedicular approach. We're going to show some of the cement. To be used, it's mix and go. It has a 18-minute working time. It also has these tracking beads, which you'll be able to see under X-ray guidance quite nicely. Also, 18-minute working time, but also approximately 18 cc's of of cement, so quite a large amount.
Just screw this on top.
Picture that. I'm going to use this to maybe cord out a little bit. We'll put we got the balloon ready to go. Thank you. So I'm going to use their curved curette, maybe picture there. Picture there. Picture there. To kind of core it out. That's on the lateral view as well. Take a look. We have a 15 millimeter balloon. It's up to 700 PSI. Picture there. Picture there. Picture there. Picture there. Picture there. Picture there. Picture. Picture. It's kind of coring that vertebral body out so to help provide some room for that balloon to go towards. Picture. Okay. Good. Enter.
Picture.
I'm going to back it up a little bit, maybe. Picture there.
Picture. Picture.
Good.
Picture.
Excellent. As you see, both markers are outside the trocar,
Picture.
and you can deliver up to 700 PSI.
Picture.
Well, of course, well below that. Let's see. Excellent. Keep going.
Picture. 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 Picture.
Stop there. Let's go to AP view. Let's just see how we're doing on the AP view as well. Any questions or comments so far in the audience? Doug, picture?
Hey, Doug, Louis, can you also comment about cleft filling and angulation of when you come in superior end plate, where you're trying to push which areas and how much to push?
Yeah. So
Picture there.
come in from the top.
I see you've got fairly contralateral there, that balloon. Picture there. Leak towards me a little bit. Picture there. Actually, not bad. Actually, true AP. Actually, looks decently. Of course, we inflate the little balloon a little more.
Inflate it.
But we, of course, do it more in a lateral position.
So when you come in from the top, you want to make sure.
So I didn't really hear the question. Sorry, Doug. Go ahead.
The question was two questions. I mean, the reduction whenever there's a cleft and the filling of the cleft itself. So
Sure.
I'll go ahead and take that one. If you want to reduce not in the cleft, below the cleft, you want to fill not only in the cleft, but around the cleft.
Yeah.
There's literature on this. So if you fill the cleft and the cleft only, you can refracture around the cleft. If it has scoliosis, the cleft is a hypotrophic or oligotrophic non-union. That's what it is. And for some reason, we have difficulty recognizing that in the spine. If it were a femur, you couldn't walk on it. And if it's a femur and it's broken and the ends don't grow together and the callus is underformed, oligotrophic or hypotrophic non-union, sometimes fibrous union. In the spine, that's a cleft, instability of cleft, fluid-filled cleft, air-filled cleft, but a cleft nevertheless. And so you need to fill that cleft and fill around it in the medullary and cancellous bone around the cleft. So sometimes I've seen cases if you just fill the cleft, in cases of kyphotic people, it spits out the front. Scoliotic people, it will come out the side. So it's not anchored in the bone well enough.
In addition to that, if you're talking about clefts within the superior inferior end plates, there are techniques we can use as well to help alleviate those clefts. Used to help steer away the balloon and also kind of help get that actual, I want to show this. Let's kind of show it at least what it looks like. So you can see, if we had a superior end plate fracture, we steer the Typhon assist away from the actual area. We're going to inflate a balloon. Go ahead. So it can help steer that balloon insertion and inflation away from that cleft and either get it more to an inferior trajectory, or it can also be used to help lateralize or medialize your trajectory to get more across. But it can be useful for the clefts that you're talking about, so good question. It's a nice way to, some alternatives to help protect yourself away from that area. Another way of actually safeguarding against these clefts are, first of all, putting some cement into that region and then reinserting the balloon. I know with Medtronic, if you now, you can deflate that, 5 minutes of working time where that balloon can still be in contact with the cement without giving you problems of destroying the balloon. But that's a good way of actually help sealing off those clefts that can cause some leakage into the disc. Questions regarding that at all?
Other questions or comments?
So we're going to deliver that cement, and again, instantaneous work, mix and go. Also, 18 minutes of working time, so a lot of time, but also 18 cc's of actual workable cement. Picture there. Picture there. I'm going to just push it a little deeper. I like to start from a more deeper portions, and that way I'm filling from anterior to posterior. And see, Dr. Raza is delivering the cement. Step away if you want. Got some extension for that delivery.
Picture. Picture.
I can see some of the tracking beads there. Let's go back to the x-ray, please.
Picture. Picture.
See little beads there that help kind of highlight the cement even more so. Those patients were difficult to see the vertebral body or difficult to see the cement. So it's nice to help highlight where you're delivering the cement.
Picture.
Fill her up, Dr. Raza.
Picture. Picture. Picture.
Excellent. Let's maybe get an AP view. Let's have a look.
Hey, Doug, could you give a comment where you preferentially want the glue, and then what kind of volumes would be best?
So one of the question was a comment on how much cement and where we want it.
Picture there.
And we want the cement in between the pedicles, end plate to end plate. And you want enough cement to accomplish that goal. This is an intra-body strut. If I see The most common error in all of vertebral augmentation is insufficient cement. So cement, just think of cement just like everything else in life. More is better, right? More cement is better. So that's what we want to accomplish, go between the pedicles, end plate to end plate, intra-body strut.
Excellent. I think we're good there. But yeah, I'd probably put a little bit more cement here, help it gather a little more to the superior end plate there, but I think you get the gist of it. I think we're good. Excellent. But any other questions I can answer for you guys? Any concerns? But that's the, and that's done for the parapedicular approach.
Nicely done, Dr. David.
If you want to go back to, thanks very much, guys.
You bet. All right, guys, we're going to transition. I'm going to give a minifying existing barriers to coding and billing, and then we'll, after this, we'll break for lunch.